Hello, I just wanted to talk a little bit about abdominal assessment. So this week, this is the focus. It's really important that you are aware of the different quadrants of the abdomen and that you have an idea of the different organs that are located within them, because if a patient's having pain, then you can locate the particular area and I try and identify the cause of that pain. So this is something that you're just probably going to have to memorize in the different areas, but it's really good to be able to have these memorized as part of your assessment technique. The other thing that's really important to sort of refer to is to think about the fact that a lot of abdominal pain will cause what we call referred pain. And so a person might be experiencing pain in one area, but it radiates to another aspect of the body. So it's really important to have an idea of exactly where that referred pain might be. So again, take a look at the diagram and really get familiar with those areas. So for example, liver pain, they may have that experienced in that right shoulder, okay? Just so that you can identify that when they present to you. The other thing I want to point out about abdominal assessment is that we do it in a little bit of a different order than all of our different assessments. So we're going to do inspection, then auscultation, and we do auscultation before percussion and palpation, and that's because percussion and palpation can stimulate bowel sounds, and so we may not be getting then an accurate idea of what's going on with the client. So when we think about inspection, that's when we're really looking at the contour of the abdomen. We're observing even too when we're looking at them, how are they moving? Are they guarding? Are they having pain? What's their facial features like? That can tell you a lot about sort of what they might be experiencing. The other thing that you can look for when you're doing inspection of the abdomen is for the presence of an ostomy. So you're looking for that stoma if they have one. Okay, and that's when you can look for the stoma to be nice, pink, warm, moist. Okay, abnormal findings would be that it would be black in color or dusty color if there's any kind of smell. And at that time too, you could be looking at the characteristics of the stool and noting any odor that goes with that. When you're doing auscultation as part of your assessment, you're really looking for the presence of any abnormal sounds. So what we would call hypoactive or hyperactive sounds. So hypoactive is going to signify a decrease in intestinal motility, and that can be caused by things like inflammation, paralytic ileus, which is sort of that paralysis of that intestine, peritonitis, which is sort of an infection of the lining of the abdomen. Abdominal surgery can cause hypoactive bowel sounds for 1 to 2 days after surgery. Bowel obstruction in the later stages will have hypoactive bowel sounds as well. Okay. Hyperactive then are pretty much exactly the opposite. So they're going to be an increase in motility within the bowel. Okay. And so early stages of a bowel obstruction will have hyperactive sounds. Other things that can cause these sounds would be gastroenteritis and things like diarrhea. Okay, so when we're auscultating, we really are listening to all 4 of those quadrants. And remember that if you're going to state that bowel sounds are absent, you have to listen for that full 5 minutes in each quadrant. Okay. The other thing you're listening for are those vascular sounds. So the big abnormal one I want to point out would be the presence of that bruit. Okay, so that would be could be a sign of an aneurysm. So just remember, if you ever hear a bruit during your auscultation, we're not to then continue with palpating that area. The other thing then I want to just point out is when you're percussing, okay, you should hear tympany over a majority of the abdomen. You will hear dullness over any of the major organs, and that's actually going to help you to identify and locate different organs. Okay, dullness in other places though, could it be identify the fluid within the abdominal cavity or any sort of abnormal mass. Okay, so it's good to note those. And then the last one, palpation. This here, you're really looking and feeling for the presence of masses and identifying any tenderness. And so if you know that a particular area of the abdomen is really, really tender, you do want to leave that area to palpate last, because it could then impact your ability to palpate the other areas. Okay, so that's the basic aspects of the assessment. The other thing that I want to point out is what you will see a lot of with clients is abdominal distension. Okay, and so there's those 7 F's, which are the reasons why someone might experience distension. So it could be from obesity or fat, from gas, from fluid, from feces, from fetal growth or our fetus, and from fibroids. Okay, so it's really important though, if you know abdominal distension, to try and be able to identify what's causing that. Okay, and so abdominal distension isn't necessarily a condition on its own. It's usually a symptom of an underlying disease or dysfunction within the body. Okay. So abdominal distension, generally what you see it's from is from air or gas, from fluid or ascites. And that can be caused from things like liver disease or congestive heart failure. You might also see it because of the presence of a tumor, and even just from a lot of feces within the intestines, from constipation or individuals with irritable bowel syndrome. Those are some of the main reasons why you might see abdominal distension. Okay. So again, if it is fluid, when you're doing your assessments, you're going to be looking for that fluid wave shift over the abdomen to identify that indeed it is fluid. Okay. The last sort of condition I want to discuss then would just be that clinical portrait of intestinal obstruction. Okay, so some of the key symptoms that you're going to see in your client would be things like nausea and vomiting, cramping, abdominal pain. Very likely going to have abdominal distension, particularly by day 2. Okay, so a lot of the things that we talked about previously. Okay, and they're also likely to have fever. Okay, so this obstruction could happen in the small or the large intestine, and it's sort of the idea that somewhere in that intestine is obstructed, and then the food can't move through the bowel, okay? And the food piles up, and this creates a medium that's really, really ripe for the growth of different microorganisms and bacteria, okay? There's different causes of obstruction. Things like adhesions from previous abdominal surgeries are one of the biggest causes, I would say. And this would be because fibrous bands formed after surgery. Tumors in the bowel can be another reason. Okay, the bowel can actually turn into and of itself. A hernia could cause strangulation of the bowel in an area as it pushes through the abdominal wall and then cause an obstruction. Or we have in younger individuals, children, in that you might even see twisting of the bowel as well. And all of those can really cause that abdominal obstruction. Okay, so really, depending on the cause and really what's going on, there can be damage and death to the intestines. So we need to really identify this right away and look for the signs of a bowel obstruction to prevent any sort of difficulty or death of the tissue in the intestines, and to also prevent the person from experiencing infection. Okay? And so generally X-ray is what's used to diagnose. So those are some of the big things. The other PowerPoint has a lot of other notes for you to look at in terms of other abnormal findings, but I hope you found this helpful.